So first things first, we're going to talk about the cardiovascular system a little bit. We know that the heart pumps the blood and circulates it throughout the body. This includes oxygenated blood going out to the tissues and then deoxygenated blood coming back to the heart and then getting circulated back to the lungs to become oxygenated again. The blood vessels are going to be the structures that are carrying the blood throughout the body. The blood provides oxygen as well as nutrients throughout the body, and those things, the blood doesn't leave the bloodstream. It stays in the bloodstream in the vessels, and the nutrients or the fluid carrying white blood cells or whatever needs to leave into the tissues, those things can then move across and out of the capillaries and into the tissues that way. Arteries are going to be carrying blood away from the heart, and veins are carrying it back to the heart, and capillaries are kind of where we have that connection kind of happening between the two. They connect the veins and the arteries. Lymphatic system we've talked about previously. It consists of the vessels as well as the tissues associated with it. The lymph nodes are the more characteristic tissues in the lymphatic system. We have several clusters in the groin, neck, armpit, and intestines, but we can have them scattered throughout the body. The spleen is also considered part of both of these systems. The spleen filters out damaged or old red blood cells, but it also filters the blood looking for pathogens. So this guy's involved in filtering the blood for pathogens, not the lymph. The lymph nodes are filtering the lymph. The cardiovascular system is a closed system and is actually highly protected from microbial infection. While we don't have a biome associated with the cardiovascular or lymphatic systems, so we think of it as being an open stadium seats, but for the cardiovascular lymphatic systems, the good thing with those guys is that it's stadium seats that are guarded by just a whole ton of protectors. We've got so many white blood cells floating around in the bloodstream and the lymphatic system that provides a lot of the protection there. And we need that protection because the blood is feeding into all of the tissues of the body. So if microbes start moving around in that system and getting out to the tissues of the body, that would be a huge problem. So the lymphocytes, the phagocytes, other white blood cells that are involved in innate and adaptive immunity, all of these guys are found in the blood and the lymphatic system in high numbers. Anytime you have a disease of the blood or condition of blood, we call it anemia. So if we talk about anemia, an is without, emia blood, so you don't have as many red blood cells as you should have. Viremia, we have viruses in the blood. These are often viruses that can cause meningitis and be transferred to the brain tissue crossing from the blood. Fungemia, fungi in the blood. Bacteremia, any presence of any bacteria in the blood. We don't have a biome, so there shouldn't be any bacteria in the blood. But when the bacteria start flourishing in the bloodstream is when we call it septicemia. So if they're actually populating in the bloodstream and like growing in the bloodstream, like it's a media that it's growing in, that's septicemia. But if any bacteria are found in the blood, we call bacteremia. Response to bacteria in the blood can lead to shock that can now become deadly if it is prolonged. I say prolonged, but it does not take very long for that to happen. All right, so again, closed system, microbes should only be present transiently while the body is clearing them out. Let's get into some of our diseases. We're going to start with COVID-19. This is the disease. This is not the virus. So the virus that causes COVID-19 is SARS-CoV-2. So SARS stands for Severe Acute Respiratory Syndrome, and it came from, we will talk about SARS in the next chapter, but SARS is actually a disease of its own, and we named the virus after it. This is a coronavirus, which is a type of virus, and this is SARS-CoV-2. SARS-CoV-1 virus is associated with SARS. SARS-CoV-2 is associated with COVID. And so these are different viruses that are very related to one another, but they are considered different species of viruses. Severe acute respiratory syndrome came around in like the early 2000s, and it was an outbreak in like China and other countries in Asia. And it was pretty severe, and people were getting very sick from it. And we were very concerned that it would come to the United States back in early 2000s, started in China. And we actually, restricted travel to and from those locations to prevent it. However, when COVID finally came out, it was a worse version of the virus and had a much more devastating effect across the world, as we are all aware. So this is a coronavirus, and this one's associated with, we say it is a cardiovascular disease. Even though we consider it to be a respiratory disease, that's how you contract it. It moves without all of the cells in the body, and it can infect for almost every cell in your body. And so it gets disseminated by your circulatory system because of that. It can infect any cell that has the ACE2 protein on it. And this is found on your lungs, brain, heart, blood vessels, kidneys, liver, placenta, and gastrointestinal tract. So this guy can infect pretty much any of your cells in your body. Yeah, and it's transmitted, it is airborne, it is transmitted via droplets in the air, but it does basically disseminate and cause widespread symptoms throughout the body. Different mutations have led to different variants of the virus. We had Alpha, Delta, and Omicron that deviated from the original virus, and each version was considered to be more contagious and worse of a disease than the previous one. And so we think about Delta and Omicron, them telling us about how it was coming out, and, oh, everybody prepared. But when we saw COVID originally come out, people were getting put in the hospital left and right. So why weren't people getting put in the hospital left and right when Delta and Omicron came out? The vaccine. Dead serious. Okay. So the vaccine, this is very key actually, because when we think about how this guy will cause disease, the vaccine has a very key part in playing how we aren't having as serious of a disease as a result of it. First, the symptoms of COVID-19, most of us are aware of it. Very prominent respiratory symptoms associated here, cough and things like this. Infection can set off a cytokine storm. So this means really significant high levels of signaling for an inflammatory response, even though it's uncalled for the level of infection that's going on. Clearly, if you can have COVID and just have like a flu-like disease, that might be the effect of having COVID. But the people that were dying and winding up in the hospital, that was because the virus was signaling their body to over-respond. Those deadly effects of the virus weren't from the virus. They're from their body over-responding to the virus. So the deadly effects of COVID were due to the inflammatory response that was being signaled by the cytokine storm effect of getting the infection. Get the vaccine, tell your body how it's supposed to respond to the virus. You might still have the virus, but your body is responding in an appropriate way without overreacting with cytokine storm. Now you've saved lives because you've just completely subverted that cytokine storm symptom of this. Yes?
So sometimes when people get the vaccine, they get sick for the day after because they're kind of injecting the vaccine. The virus into their cells?
The vaccine does not have the virus, period. There's no virus in the vaccines.
Is it just like their body's reaction to it?
So you tell me, what do you think is going on? Any guesses?
I think it's the same as like when you get a flu shot in your arm.
Right, so why is that? Right, it's the immune response that's doing this. Your body is, right, everybody's, so that's the thing, right? And that's the thing that we talk about with the immune system. What happens for your body to make your immune cells? Your genes reassort. And so everybody is different with how their genes reassort to respond to the different antigens that you could be exposed to. So how your body reassorted your genes, you had a different kind of reaction or different strength of reaction. You had a stronger one probably that like didn't involve as much waiting on the inflammatory response, and yours was faster. But your family members may have had reassorted genes that they had to wait a little longer to get a strong enough response. However, the whole point is training that immune system in the end so that if you actually see the real virus, will respond with proper response instead of having this massive inflammatory signal sent out from the initial exposure. And so that's the issue there. And so a lot of times whenever we get our vaccines, the symptoms that you can get from getting the vaccine, some people might have none. I have only ever had a side effect from a vaccine one time in my life, and that was from the COVID vaccine. And I got that COVID arm. My whole arm like was red, and like swollen too. And so my whole arm was like that. But that's the inflammatory response responding to the antigen. And then when I have gotten COVID since then, I still got COVID, but I didn't wind up in the hospital, right? And so that's the idea of training that immune response there. But yeah, my initial response to that, I mean, I've gotten flu vaccines, tetanus, like all the vaccines that I'm supposed to be getting. I've never had a side effect until COVID. The way my body responded to that COVID vaccine. So that's your immune response doing that, yes. And so it's not the virus that's causing that. It's the immune response. Now, can viruses that you get infected with actually cause damage to your body? Of course they can, especially what we're going to be talking about with like Ebola here in just a little bit. Obviously, that's not your immune system that is doing that. The virus is causing effects to the cells that are causing that. But a lot of the time, when you're sick with these basic flu-like or cold-like diseases, it's almost always your immune system that is causing those symptoms. So that's a great question that brings into that concept of how the immune system is responding to these things. And inflammation is uncomfortable, man. It's not a good time, but it's there for a reason. So COVID, we had the cytokine storm, and that was what was typically associated with the deadly effects of COVID. We had systemic effects of the virus, skin rashes, muscle pain, heart damage, joint pain, blood clots, some of it from the virus, some of it from the immune response. And it is also a neurotropic virus that can affect the nervous system as well. And so people can actually have a nervous system illness associated with COVID if it does infect the nervous system. And that can lead to dementia, cognitive decline, and that can be a very serious thing for some people that get it as well. Up to a third of people that are infected with COVID won't have any signs or symptoms, again, related to how their immune response responds to it. And so a third of the people during the COVID outbreak that were walking around with masks on, thinking that they were avoiding getting COVID, there might have been, of all the people involved infected with COVID, a third of them walking around with masks on, trying to think that they don't want to get infected, and they might have actually been spreading around the whole time. It could have been you, could have been me, I don't know, right? All right, so of course we had social distancing, hand washing, sanitizer around, and everybody was masking up as well to prevent this. And it actually controlled it pretty well until we started having introduction of the vaccine. And the vaccine really did the heavy lifting for us and allowed us to become a society that was interacting with one another again. The two different vaccines that were developed, the Moderna and the Pfizer vaccines, are mRNA vaccines. Literally, we're injecting you with the mRNA, and then your cells will turn that mRNA into the COVID spike protein, and then your body reacts to that. I think I had the Moderna one, but Johnson & Johnson vaccine works differently. We took an adenovirus that was just a normal cold virus, and we just made it express the only gene that it could express, was able to express, was the COVID spike protein. And so it was just a regular cold virus with COVID spike protein on it. And so that made it less likely to have cytokine storm being initiated and everything. We could just react to that spike protein. I have had students ask me, like, if you're somebody who has immune system issues, or maybe you have inflammatory problems, or you have cardiovascular symptoms, which of the vaccines is better for someone like that? And I don't know the statistics on that. So if you guys find out, I'd be happy to know, so I could pass that information on. I haven't done the research on it to see if there is. I don't think that one or the other is more likely to have those effects, but if you do the research and you find out, let me know. There were medications that were used, antivirals that were used to treat COVID as well. I'm not going to test you on them, but there are antiviral medications that can help with the infection if needed. All right, moving on to endocarditis. Endo is inside, cardio is the heart, and itis is inflammation. So inflammation of the inner linings of the heart, which is called the endocardium. This can be either presented as acute, so we'll have stronger symptoms right up front for a shorter period of time, or it can be subacute, so it's usually a long-term, more chronic presentation, and you'll have milder symptoms, but over a much longer period of time. What happens in endocarditis is we have damage to the heart valves, and this can basically, if you have damage to heart valves from either you might have a fake valve, or you might have had surgery in your heart, or you might have just heart disease in general, it's already leading to that, that can predispose you to infection in those areas, that damage. And the inflammation can be due to just an inflammatory response. But in the case that it is an infection, this is often going to have other infections going on in the body besides just in the endocarditis. It's just something that will move from other areas of the body. You get a respiratory infection, and then it would move to the heart, then to endocardium, as a result of it being in a nearby system. That's what we would call a focal infection. We have local if it's just in the respiratory system, but if it moves to a nearby system, then it becomes a focal infection. So signs and symptoms of acute endocarditis would be fever, anemia, abnormal heartbeat, symptoms of heart attack, shortness of breath, and chills. And so this would be the general presentation of the disease. But then some other things that come along with it would be abdominal or side pain. This could be due to inflammation now through the larger blood vessels of the body, as well as in the spleen. So now the spleen is probably having to work overtime, dealing with damage and inflammatory aspects in the immune system, as well as damaged red blood cells. And so the spleen can become inflamed as well as a result. Janeway's lesions and Osler's nodes. These are basically like spots that you'll get either in your nails or in the calloused areas of the skin that are due to ruptured like blood cells. And so you get like looks like a scab or something growing out under your nail. That's Janeway's lesions. Anyway, so if you have subacute endocarditis that's going on for a much longer time at a lower level, you have similar symptoms, usually at a lower degree. It'll develop more slowly, be less pronounced. And then other things that come along with it over time will be an enlarged spleen, so splenomegaly, Again, dealing with the damage and inflammation associated with the endocarditis symptoms throughout the circulatory system. Clubbed fingers and toes can also result from this. So I want to be very clear about this too. Having clubbed fingers and toes is not a natural, it's not a genetic thing. You should not have clubbed fingers or toes, and neither should any of your loved ones, even if they've had them their whole life. It's not a genetic thing. So if you don't know what clubbed fingers or toes is, it's when like the nail, instead of if you hold out your nail, my nail comes out relatively straight. I mean, it has a little bit of curve natural to it. But when people have that very rounded appearance of the nail and it is wider on the finger, that's what we call clubbed nails, clubbed fingers. So it's a much rounder appearance in the nail, and the nail bed is widened out and rounded. That's clubbed fingers, and that can happen in the toes as well. That's always a sign of something wrong, always. And so it's either because of endocarditis, maybe, but there are like genetic like diseases that can be associated that can lead to that. We're not saying that it's not a genetic trait like having brown hair or blonde hair. It's not like that. It's like you might have a genetic deficiency. You might have, more commonly, it's associated with like nutrition deficiencies. And that can be due to metabolic disorders as well. But if you have somebody that has clubbed fingers or clubbed toes, there is something going on underlying, usually, in their medical situation. Again, nutrient deficiencies and things like that can lead to that, but it's not something that you have naturally. All right, sepsis. So this is also, we call it septicemia. So again, this is when we have overgrowth of bacteria within the bloodstream. They're actually populating within the bloodstream. And so this will occur whenever like bacteria start multiplying in the blood. They got in there maybe through a cut, or they got in there through some other infection that led them to populating within the bloodstream. Signs and symptoms will be fever, altered mental state, severe shaking, chills, and gastrointestinal symptoms. This is like in the earlier stages. Almost always, if you have sepsis, this will end up being a deadly thing. You don't get over sepsis. You have to be treated for it. And so if it's untreated, any type of sepsis, if it's untreated, will lead to death. And so this is something that has to be taken very seriously. There shouldn't be blood populating in your, there shouldn't be bacteria populating in your bloodstream. This is always a sign that something serious is going on. What happens is that due to the inflammation that's actually happening in your bloodstream and is disseminating throughout your body, is you'll have systemic effects from sepsis. And then that will lead to increased breathing rate, respiratory alkalosis, low blood pressure, shock response a lot of times is very common, and loss of fluid from the vasculature and into the tissues. So you could have edema of the tissues as well, as the body's trying to basically deal with this systemic infection all throughout the bloodstream. And then, of course, you have other infections that can develop from that later on. More likely than not, sepsis is going to result from, it's like a secondary aspect to another infection, but you can have sepsis by itself. You should be, like, if you're somebody who's aware of like your typical health, or like your family member child or something's typical health, if they're getting a fever or something and you have no other way of explaining it, like if the flu is going around and your kid gets a fever, then it's probably the flu. But if your kid has a fever and there's nobody else has been sick, or the kid hasn't been around somebody sick, then you want to take them to the doctor and they can check for things like that. But yes, it should be like you'll have early enough signs before it gets to it being deadly. Yes. Mm-hmm. It could be, it could have been. And of course, when we think about like breathing, when you breathe in the oxygen and everything like that, and it gets transferred into like your blood cells carrying it around, like there's an exchange happening there that some of the bacteria are able to cross that barrier and then become part of the bloodstream, especially in people who are older and they have a weaker immune system, that risk is much higher. So it's probable. There's no way really of knowing for sure which came first, right? And so that's the issue too. Sepsis can start off slow, but it also can be very quick. The bigger issue with sepsis will be like endotoxic shock. So if you get gram-negative bacteria in your bloodstream, your body sees endotoxin as a PAMP, and we have this massive inflammatory response to that PAMP. And so this is very common with gram-negative bacteria that get into the bloodstream to have a shock response. You will have a drastic loss of blood pressure. And if this isn't contained earlier on, this is whenever we have the risk of death. It's usually due to that loss of blood pressure, poor exposure of oxygen to the brain, and you would slip into a coma and they could eventually die as a result of that. Gram-positive bacteria might have certain toxins or markers that can instigate a similar reaction. This is what we see in toxic shock syndrome with like tampon usage and things like that. It's gram-positive bacteria, but they have other toxins that elicit a similar response. Moving on to the plague. There's 3 different versions of the plague: pneumonic, bubonic, and septicemic plague. And they're in the names what kinds of disease is going on. The more common, like the least deadly one. The least deadly one is bubonic plague, believe it or not. So bubonic plague. So this is always bacteria that are transmitted by flea bites, and we're going to talk about bacteria in a little bit. But the disease itself, in bubonic plague, we have infection of the lymph nodes that we call buboes. And so the lymph node themselves is being infected by the bacteria, and they swell up to where you can actually see them through the skin. And those are called buboes, an infected lymph node. So whenever you get mono as well, that's a viral infection, but mono also infects in the lymph node. And we technically would call that a bubo as well because it's infected in the lymph node, though it's usually more commonly associated with bacterial infections. So infected lymph node here, the actual lymph node is infected. That's a bubo. And so bubonic plague, we have infection of the lymph nodes. You can have movement of bacteria into the respiratory system as well. If you have the bacteria in the respiratory system, you can then spread it from person to person. You don't need the fleas to transmit it. So the pneumonic plague, when somebody has it in the lungs, they're able to transmit it from person to person that way. And then we have the septicemic plague, which is the one that we call the Black Death. So what happens here is that we have disseminated coagulation, subcutaneous hemorrhage, and purpura. And what happens is the tissue damage and death of the tissue that the bacteria can start feeding off of the necrosis, and that just contributes to more of the necrosis. And so we see development of like black extremities and things like that. So people will get black fingers or black toes, especially in those fragile capillary areas in the extremities. And that's why we call it the Black Death, is because literally the tissue will be turning black from the necrosis. It's a 30 to 50% mortality rate if we give you all of the treatment that we have available. 30 to 50% if we give you everything we've got. If you don't get any treatment, again, all septicemia, if you don't get treatment for it, you're going to die. Yeah. So the bubonic plague, here's some pictures of some buboes in the groin area of someone. So those are buboes. And then this is caused by bacteria. It only takes about 3 to 50 cells to cause bubonic or septicemic plague. So it doesn't take like a whole lot of exposure, though you do have to have introduction of some of these guys. And it's caused by a bacteria called the Yersinia pestis. It's gram-negative bacteria transmitted by the fleas. We do have the plague here in the United States. This hasn't gone away since like the Dark Ages. It's still here around in the world, and it's still all over the place. In the United States, where we have it, it's maintained in rodent populations. And rodents that primarily spread it to humans are going to be prairie dogs. And so if you're a hiker or somebody like that, and you're going to the Four Corners area of the United States, the prairie dogs in these regions are infested with plague. And so if their fleas bite you, then you get the plague. It is a BSL-3 level infection. And so we will quarantine you. You'll be in your own room. We'll be calling the CDC, and we'll be like making sure everybody you contacted is like quarantined as well. And so there's those sorts of situations that could be happening there. So this is all of the cases of the human plague that we've had from 1970 to 2017. That's all of them. So it's not a ton. It's pretty uncommon. But if it did, get transferred from the blood or the bubo infection and get transferred into the pneumonic, then it can spread from person to person. And so that's where the real risk comes from. And if it becomes septicemic, when you're looking at a 30 to 50% mortality rate with treatment, that's pretty serious. So we're moving on to infectious mononucleosis. This is caused by a virus. This is Epstein-Barr virus, which is a herpes virus. This is a herpes virus. It's DNA, and it does splice itself into the host DNA. So once you have had mono, you have it forever, just like with chickenpox or any other herpes virus. More than 90% of the world's population has been infected with EBV. So you're sitting in here maybe thinking that maybe you haven't had mono, or maybe you remember having mono. I don't know. I never remember. I never had the disease of mono, but I have the antibodies in my blood. So I have had it. So down here at the bottom, it says during the teen years, this will result in disease about 30 to 77% of the time. I guess it really depends on the population you're looking at, because that's quite a range. But I definitely have had it, and I've never had the symptoms. And so I had a boyfriend in college that came down with mono, and I was like, when am I going to get it? Like, I kept waiting for it to happen. So I went to the doctor, and the doctor was like, oh yeah, I mean, you have the antibodies for it. You've probably had it before. And so there's that. most people's immune systems, whenever you have mono, like I said, usually you have it forever. And so it's in your body, just like the chicken pox, just like any herpes virus, cold viruses, cold sore viruses, herpes simplex virus 1. So we've all probably had it. And then your body's keeping it at bay with the immune system, the immune response. And it inserts itself into your DNA. And sometimes that can disrupt your cell cycle of your DNA and can actually cause cancer. So your immune system is potentially also keeping the cancer that this guy can cause at bay as well. And we know this is true because people who have HIV are likely to develop Burkitt's lymphoma, which is associated with having mono. Their body can't keep it under check anymore. And so they end up getting cancer from it. So once you have it, some people, their immune systems don't keep it under check very well. And so you can just have recurrent cases of mono. And that's something that you'll probably hear if you talk about to other people. They might have family members that randomly will just have mono. They get stressed. It's just like with herpes, you get stressed and then you have an outbreak associated with that. It's the same thing with mono. Same thing with chickenpox and shingles too, right? Just depends on that person's immune system. But that's mono. All right, moving on to anthrax. We talked about cutaneous anthrax in chapter 19, but anthrax can also be disseminated through the bloodstream, which we would consider to be septicemic version of anthrax. This is a possible outcome of all forms of anthrax. They can all move into becoming the septicemic version. So the different versions of anthrax that we have down here, the skin one is cutaneous, the lungs is pulmonary anthrax, the gastrointestinal anthrax, and then nervous system anthrax develops into meningitis. So it's anthrax meningitis. This is a zoonotic disease. It's maintained in herbivore populations. This is a livestock disease primarily, but it's also a threat for bioterrorism because it is a pretty serious disease. We already talked about cutaneous anthrax being like 20% mortality rate if it's not treated. Septicemic anthrax, of course, septicemia, we've already mentioned, it's 100% fatality rate if it isn't treated. Can you treat anthrax with antibiotics? Yes, there's antibiotics that are available for this. But sometimes if it is going straight into the pulmonary form, or if it's going straight into the septicemic form, that the likelihood of you dying from it is going to be higher if you don't get treatment like immediately. So there's the issue with that. This is a gram-positive endospore forming rod. All of our endospore formers are gram-positive. So if I were to ask you some questions on the test and be like, oh, little Joey Schmidt got Clostridium perfringens. I don't know what he did to get the Clostridium perfringens. He got stabbed in the side by his friend. They got in an argument. He got stabbed in the side. He ended up getting gas gangrene. And you do a gram stain and it was purple. Does that confirm like your suspicions of the causative organism? It should, because all endospore forming organisms are gram positive, and Clostridium is an endospore forming organism. So there's some follow through we could do with that, and thinking on that like higher level, thinking of how these terms are going to relate to one another, which is what I'm going to expect on the final exam. All right, hemorrhagic fevers. These are, you're going to have a literal fever. That's why they're called fevers. So there is going to actually be a fever involved in these. These are bloodstream or lymphatic diseases, always accompanied by the fever. And we call it a hemorrhagic fever because hemorrhage is associated with it. So we have fragility of the blood vessels, and like especially the capillaries are likely to burst in these diseases because a lot of these diseases somehow affect how the cells like stick together. And so it can weaken those bonds with how the cells will stick together. And we have literal leaking of the contents of your blood vessels into the tissues or out of the orifices of the body. So these, many of these are transmitted by mosquito bites, not all of them. These ones are caused by Aedes mosquitoes. Aedes mosquitoes transmit these guys. And we do have these mosquitoes in the United States. In the United States, we do not have yellow fever. Yellow fever is endemic to Africa and South America, and it's present more in the rainy climates, again, where mosquito populations are common. And yellow fever is a hemorrhagic fever. Dengue fever. This is endemic to Southeast Asia and Africa, and we have had epidemics in South and Central America and the Caribbean as well. So this is not uncommon now in South America and even in Central America. And we've had a few cases in the United States as well. We don't consider it endemic yet, but it does seem that our mosquito population can harbor dengue fever. It's a hemorrhagic fever, but it's not usually associated with hemorrhage. You don't always hemorrhage from that. And so it's actually causes what we call break bone fever. And so it causes a fever that is so severe that the chills can have actually been known to cause you to break your own bones from like the shivering and stuff associated with the fever with this guy. So dengue fever is not something you want to mess around with. It's being very well studied by a lot of scientists around the world, and it can be very serious and can lead to permanent neurological defects as well. Most people will recover from it on their own, but it is not a disease that is comfortable to have. Then we have chikungunya, which sounds like a crazy name. It was endemic in Africa and Central America. And in 2013, it moved into the United States. This is something that is endemic to the United States. So we see it primarily in the southern portions of the US. So Texas and Florida are more commonly where you'll see cases of chikungunya. And we don't see it coming out a lot, but it is in our mosquito population. Again, not common for this to cause hemorrhagic fever, but it has the propensity to. And again, most people, this is similar disease to dengue, but maybe a little less severe than dengue. It presents very similarly to that. These are hemorrhagic fevers that are not spread by mosquitoes. And we actually know this about Ebola. Ebola is not spread by mosquitoes, it's spread from blood contact. And so what happens with Ebola is we have very severe weakening of the connections of the cells in the blood vessels. And so we're bleeding from orifices and even can eventually have such weakening in the skin that we could potentially bleed from the skin and things like that. So we think that bats harbor this naturally, but we haven't been able to prove that yet. And that's being spread throughout maybe the primate populations, and that we have tribes in Africa that rely on primates for bushmeat to feed their families, and primates and other animals that can potentially be infected with Ebola. They contract the disease, and then authorities might come in to try to help out with the outbreak, and then they contract the disease. This is a pretty self-limiting infection though, because once it does transfer to what we consider developed countries that have proper hygiene practices, that we're aware that we shouldn't be touching the blood of somebody that is bleeding out. It's a general concept that seems obvious to us, but maybe in these tribes, they haven't had that type of exposure before. So this is a pretty self-limiting infection. We don't see massive outbreaks of Ebola once it gets to developed countries because of the awareness of hygiene practices. And the likelihood that if somebody is bleeding out and that you would be contacting the blood, and it does require contact with the blood in order to spread the disease. It's not airborne or anything like that. There is a strain of Ebola that's airborne within primates, like non-human primates, but it hasn't spread to humans yet. Ebola is a disease that there are strains of Ebola virus, many strains of them are 70 to 90% mortality rate. And there aren't antivirals that can treat it. But we can provide immunoglobulin from survivors to people that have the disease that looks like they're not going to make it. And it does have some efficacy there, but when we have larger outbreaks, there's limited amounts of immunoglobulin that we would have. It also seems that Ebola can be harbored within the testes of men that have recovered from it, and that they can continue to pass on that virus even after they are no longer showing signs of Ebola. That's terrifying to think about. Measles and mumps do the same thing, I believe. So that's interesting to think about too. Or loss of fever. Most people that get loss of fever, if you're exposed to it and you get an infection with it, you won't have symptoms. Like 80% of people are asymptomatic. But the 20% that get the disease, it's a horrible hemorrhagic fever to have in the 20% of people that get the hemorrhagic fever. It's maintained within rat populations. All right, moving on to our non-hemorrhagic fevers. So again, these are diseases that are associated with an actual fever, but these guys aren't as closely associated with the hemorrhagic side. Some of these guys might, in some cases, lead to some aspects of hemorrhage, but they're not characterized by that in their disease. Okay, so most of these guys are bacteria. One of these guys is a protozoa. Let's go into it. Lyme disease, first discovered in Old Lyme, Connecticut in the 70s. It is transmitted by ticks. It creates this very characteristic bullseye rash and leads to neurological symptoms, fever, headache, stiff neck, and dizziness, as well as psychological symptoms can develop from this as well. Most people that get this will not recover on their own. It is a bacterial disease, and it takes months for it to lead to its worst effects. It can even lead to arthritis over time. It's caused by bacteria Borrelia burgdorferi. It is an intracellular bacteria, so it lives inside of the host cells, and it's very difficult to treat. It takes long-term antibiotics to treat this guy. It's very slow progression of the disease, and it usually, you'll have some aches and pains, but you won't really know what's causing it. It's not getting better, and not everybody gets the bullseye rash, and so sometimes that can make it even more difficult to treat, but it is bacteria, so we could potentially treat it with antibiotics once it does get diagnosed. The immune system seems to contribute pretty strongly to the pathology of this disease and the damage that it can cause. Again, it's transmitted by tick bites. It's maintained within mammal populations in the wild, and then you get bitten by a tick and it gets transmitted that way. Next is ehrlichiosis and anaplasmosis. These guys have a very similar disease progression to one another, and it's usually something you're going to recover from like on your own without having to have antibiotic treatment. It has acute febrile state, which means you feel sick. Okay, you know you're sick. You might have headache, muscle pain, and rigors. You feel sick, and then you recover from it. And so this is also transmitted by ticks. These are hard ticks that we call Ixodes ticks. So you have the ones that are big soft ticks that fill up, and then you have the ones that are actually like hard ticks, and these are the hard tick guys. So this is bacteria, Ehrlichia, Chafensis, and Anaplasma phagocytophilium. These guys, again, very similar. You just get sick, and most people are going to recover from it. Most people will. Babesiosis is a similar disease to the other two, but it's caused by a protozoa. And so if you have the signs and symptoms that you're not recovering from, and we need to treat you, that these can be treated with antibiotics and antiprotozoals. We usually aren't going to try to diagnose which one you have unless there is some issue with you recovering from it. And we'll just treat you for all of these: Ehrlichia, Anaplasma, and babesiosis. So we will have combinations of antiprotozoals and antibacterials, antibiotics, to treat the diseases, just like the signs and symptoms. Coming from tick bite, we think it's protozoa or bacteria. Here's some medication, and that's pretty much how we will treat that. Moving on to spotted fever, rickettsiosis. The more common one that we're aware of is Rocky Mountain spotted fever. This is caused by a bacteria, Rickettsia rickettsii, and easy name at least. It is also transmitted by hard ticks, and this one is found all throughout the United States. So are ehrlichiosis and anaplasmosis. But again, it's not as serious of a disease, so we don't worry about it as much. But Rocky Mountain spotted fever is pretty serious. So we have chills, fever, headache, muscle pain. So you start feeling cold, flu-like symptoms. Then you'll have a spotted rash that will develop a few days after the first signs and symptoms that you'll have. That's called the prodrome. So if it's left untreated, then those lesions can merge, and they could potentially become necrotic. And you can also potentially have development of hemorrhage as a result of this. It's not common for that, so that's why we don't consider it a hemorrhagic fever, but it could potentially lead to similar symptoms of that. 20% mortality rate for this guy if he is untreated, so we'll give antibiotics for this. 20% mortality if it's untreated, but it's still 5 to 10% mortality rate if it is treated, and that's pretty high. I've even had a student who was a paramedic who was going into nursing school who contracted Rocky Mountain spotted fever. She went to a location for emergency and got bit by a tick at this rural location, and she ended up getting Rocky Mountain spotted fever, and she was in the hospital for months with this, recovering from it. And it was horrible. And I've had other students that'll tell me that they've had loved ones that have had this, and it's usually like you don't hear a story about somebody getting over this in a couple of weeks. This is months of debilitating disease, and people are lucky to survive it. Honestly, 5 to 10% mortality rate, that's pretty high. That's with the treatment, and that's pretty surprising. So this is an image of the characteristic rash that is associated. You get this again 2 to 4 days after you start having the other symptoms. Moving on to Chagas disease. Chagas disease is transmitted by a bug. It's this bug. This bug is either called the assassin bug or the kissing bug, and the more scientific name is a triatamine bug, and they look like this, and they bite, and then they lap up the blood from where they bite. And so you might be like, oh, crazy, glad we don't have those. Hate to break it to you, these bugs are all over Oklahoma. They're extremely common. They don't always carry this disease, but they can carry this disease. And so we haven't had a massive endemic issue with Chagas disease in Oklahoma, but this isn't uncommon in Texas. And so sometimes you'll have some cases coming out in Oklahoma. So Chagas disease is caused by a flagellated protozoa. This is a protozoal disease. This is Trypanosoma cruzi. And so signs and symptoms, acute version of the disease, you'll have severe fever, you'll have nausea and fatigue. And so you'll feel sick. You'll be real sick for a while. And you really usually typically are going to need treatment for this. It's not something you recover from usually like naturally. So, and the Chagoma. Chagoma is the swelling near the bite site where the bug bit you. So it swells up. What these bugs will do is they will bite you, lap up your blood, and then defecate while they're eating. And when they're defecating while they're eating, the protozoa are in that defecation fluid, and then it can migrate in through the skin and then cause the infection there. And then that's where we'll get development of that shagoma. It's usually associated near the eyes and the mouth. That's where these bugs are kind of attracted to the moisture and the heat associated with these sites. And so they bite. And so you might, like, we don't see this a lot in adults, because adults, when they sleep and you feel something crawling on you, you'll swat it away. But we see this more commonly in babies. And so they'll get into the baby's cribs and feed on the babies near their eyes or their mouth. And if you get the chronic version of this disease, the inflammation associated with this can disrupt your circulatory system and your nervous system, as well as the intestinal tract, and can cause a much more serious disease. So I've seen these bugs. So every apartment that I've lived in, I've seen at least one of these bugs, like, just crawling around. And they're pretty big. They're like this big. They're not super small bugs. Okay, those are bigger bugs. And there's the ones that also look very similar to that one, but they're like a grayer color and they have a big wheel on their back. Those guys are called wheel bugs, and they eat like pests in your garden. They're good. Okay, but if they look like this, kill it. And they live in your house. So they like live in like the walls of your house typically. Like, they like the warmth and like everything like that and the quiet. And so they will usually live in the walls of your house. And so, yeah, I mean, you don't see them a ton, but they're around. So this is trypanosoma. We've seen it in our own slides in the lab. We saw different trypanosoma is trypanosoma gambiense, which is associated with African sleeping sickness. And so African sleeping sickness is also a different kind of trypanosoma, but it can lead to what we call exploding heart syndrome. And it's also sleeping sickness. People get so tired from this disease that they end up falling asleep doing like everyday things, sort of like narcolepsy, but they end up dying. It's a deadly disease to have. Exploding heart syndrome, it is as bad as it sounds. The heart doesn't like explode so much as the inflammation just causes it to not be able to function properly, and that can lead to death as well. All right, moving on to malaria. Malaria is a protozoal disease, and malaria overall, we have malaise, feeling like crap, fatigue, aches, nausea, and may or may not have diarrhea associated with it. And the symptoms usually cycle every 48 to 72 hours. If you have the falciparum version of malaria, you might have a cough and a persistent fever that won't cycle, and a weakness of the body that can last for weeks without any relief. And this can even move into the brain, where you'll have symptoms of the brain getting obstructed from the protozoa in the blood, and that can lead to coma and death. This is caused by protozoa called Plasmodium. It's Plasmodium, whatever these might be. The more common and severe one is going to be Plasmodium falciparum. These are found throughout the tropics of the world. We have had a few cases of malaria in the United States that we think is related to travel. We do have the mosquitoes that can transmit malaria in the United States. So it is possible for it to become a disease that could be an issue, but we usually have mosquito abatement practices for other reasons. Yes.
So when I went to Africa and came back to malaria,
Mhm.
what kind of started like hallucinating?
Wow. Yeah. I mean, the more common one is Plasmodium falciparum, but the other ones aren't uncommon. So it's kind of hard to say, and it kind of would depend on like the region. So different regions in Africa might have increased incidence of different ones, these guys. Some of these are not as common as other ones, like the Nolesi one isn't as commonly associated with humans getting malaria as much, but yeah. So these actually like replicate within your blood cells and within like your liver as well. And so they have like phases of life where they'll cycle in your liver and in your blood cells. And if you have had malaria ever, you can never donate blood, because these guys can actually become dormant in the liver tissue and can still, like, it's hard to get rid of them. It's even with the treatments, the drugs. I'm not going to go over the life cycle, but again, they will move into a life cycle in the liver and then cycle through the blood cells and then kind of go back and forth again. Depending on what stage in that life cycle you're in, depends on like the signs and symptoms that you will have as the host. They will invade the red blood cells and the liver cells, and when they do burst out of your blood cells, it releases fever-inducing chemicals into the bloodstream. It can lead to anemia of the blood cells as the blood cells are being damaged, and as well as splenomegaly, enlargement of the spleen, and the liver as well, because it's also being affected by the protozoa. The red blood cell adhesion to blood vessels in the brain can lead to those brain effects that we talked about in the previous slide. The protozoa can shift its antigens on its surface, has the ability to change its antigens. So developing a vaccine has been very, very difficult. There are vaccines that are available to some kinds of malaria, but the problem is it requires several boosters. And so when we go out to areas that have endemic situations, we can't get out into a lot of these populations. First of all, to give them the first vaccine, but also getting back there to give them their boosters to actually provide the immunity, it's nearly impossible. And so it's been very difficult to get a vaccine effort underway for malaria. Best way to prevent the spread of this disease is through mosquito abatement, so preventing the mosquito population from spreading. So we will, encourage education about how to control mosquito populations by limiting standing water, spraying insecticides. Female mosquitoes only mate once, and so they will mate with a male, and then hopefully they have eggs, and they can go lay the eggs, and the insects can develop or whatever. But we can introduce genetically modified sterile males into this mosquito population, and then the females mate with them, and then they just die and don't reproduce. And so that's proving to be an effective way of controlling the mosquito populations as well. And then, of course, protecting yourself with nets, screens, and repellents. If you're traveling to areas that are endemic for malaria, you're supposed to go see a doctor and go put on chemoprophylaxis. This means that we're going to put you on drugs that treat malaria before you go to these places to prevent you from getting the malaria. All right, again, this is just showing some pictures of that. It's the same stuff we just showed on the previous slide, though. Moving on to HIV. HIV stands for human immunodeficiency virus. We isolated it in the 1980s. We originally thought that it was causing a disease that we called GRID, which stood for gay-related immunodeficiency. So we found it primarily in the gay populations, and we say we, but humans in the past, found it in the gay populations and just assumed this was related to gay activities. And so primarily in gay male populations. However, it ended up being that this is a virus of all people. Anybody can get HIV. It has nothing to do with your sexual preferences, and is a blood-related transmission. And so, again, it's transmitted through blood and certain body fluids like breast milk and semen. It is not transmitted in urine or saliva, though. And so it requires contact with those body fluids into the blood. And so you have to have blood exposure for it to be transmitted. So if it is semen, it has to get into the blood. There are cases where breast milk can transmit it to the babies, but that is less common than when we see the blood transmissions. Anyways, this is a retrovirus. So this is a RNA virus that can turn its RNA genome into DNA and then insert that DNA into your genome, and it becomes part of your genome forever. Once you start developing AIDS, this is defined by a complex of symptoms, such as having a certain kind of pneumonia caused by pneumocystitis gyrovecii. We don't usually see this in people that are healthy otherwise. Kaposi's sarcoma, which is a certain kind of cancer, sudden weight loss, swollen lymph nodes, and general loss of immune function, all associated with the progression of AIDS. Once you have been diagnosed with HIV and you are HIV positive, you are HIV positive for life. Even if you have undetectable levels of the virus in your blood, you are still HIV positive. We define AIDS, though, by how many T cells you have in your bloodstream. And so once your T cell population falls below 200 cells per milliliter, we consider that AIDS. And you're at risk for opportunistic infections and things like that. So with AIDS, when you have HIV and the progression of the HIV disease, the HIV itself usually isn't what is causing your disease symptoms. It's going to be other infections, secondary infections, and usually opportunistic ones, infections that most people won't otherwise be getting. Though you can have symptoms of fatigue, diarrhea, weight loss, and neurological changes just associated with having HIV in the bloodstream. Many of this is going to be due to other infections that will come along with the lowered immune response. There are two major types of HIV. HIV-1 is by far the most common. There's also HIV-2. Here's an interesting little fact that I find horrifying. For all adults that are of sexually active age in South Africa, 50% of them have HIV. 50%. 1 of every 2 people. So HIV is a huge problem in the world population. And controlling HIV is a major concern for a lot of governments in protecting their people and the spread of HIV. So there are major campaigns throughout the world to try to educate people about, having protected sex. And if you know that if you have HIV, being honest with your partners about that so that people can be protected. Again, it's transmitted usually through blood exposure, sexual transmission, trauma, needle sharing are the most common. There can be spread through breast milk as well. But urine, tears, sweat, and saliva are not considered sources of infection. The global estimate worldwide was 38 million people are infected. 1.2 million infections are currently documented in the United States. And in the United States, it's estimated that 15% of all of the people that have HIV in the United States, that 15% of them don't know that they have it. So protect yourself if you are having new sexual partners, right? And make sure everybody's getting tested. The best way to prevent AIDS or HIV infection, and of course the AIDS that might follow, the best way to prevent HIV infection is of course going to be protect yourself using barrier protection. There are medications now that are available like PrEP and STEP that are basically prophylactic chemotherapy drugs. So you would take the drugs in order to prevent the infection from happening. So it does seem to be very effective at preventing infection from starting. Don't share needles. I mean, apparently you can bleach your needles. So, I'm just saying. I don't advise using intravenous drugs illegally, but hey, if you are, at least bleach your needles if you're sharing it with somebody else, I guess. You can tell your patients that. So there are a lot of medications out there now that can help with preventing the spread of the disease. And there are usually a 3-drug cocktail that affects the reverse transcriptase, the protease, and the integrase that are special to HIV, and it'll attack all of those, and that is going to provide the best protection for that. And that's what this slide is describing for explanation of how those drugs work. We've talked a little bit about this in previous chapters.